All right, so continuing with evaluation and management, we've been going through office visit codes 5 through 1. Today we're going on the level 3. We're going to be talking about the 99203, 99213. So this is the official AMA grid. You can find it printed on page 17 in the 2022 CPT book. Now, if we look at our level 3 service, our 99203, 99213, the level of medical decision making there is low. So we have to hit 2 of the 3 of the number of complexity of problems addressed, amount of complexity of data to be reviewed and analyzed, and risk of complications. 2 of the 3 have to be hit in this row to hit that level 3 service. The level 3s actually get a little bit more subjective, and we'll see that as we go through the risk level. Now, to start with our number and complexity of problems addressed, in order to meet a low level, we would need 2 or more self-limited or minor problems. Now, if we look at our definition of self-limited or minor, it says that a self-limited or minor problem is a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. A perfect example would be if you fall and you abrase your arm. You don't fracture anything or permanently damage anything, but you do have a pretty rough wound there on your arm, and that'll eventually, once it's all cleaned up, kind of heal itself up on its own. Sometimes it can be a little difficult to decipher between a self-limited or minor problem and a minimal problem. So a minimal problem is more that 99211 service, something where even if that patient hadn't received healthcare services that day, it would have likely resolved on its own. Self-limited or minor, it's something that runs that prescribed course, it's transient in nature, is not likely to permanently alter health status. So 2 or more self-limited or minor problems would meet that qualification here for a low number and complexity of problems addressed, or just 1 stable chronic illness, stable meaning that the patient is at their treatment goal as designated by their provider. So just 1 stable chronic illness will meet that criteria. Or it could also be 1 acute uncomplicated illness or injury, which that sounds kind of confusing. You might think, well, what's the difference between a self-limited or an uncomplicated acute illness? So we have a definition here. So an acute uncomplicated illness or injury is a recent or new short-term problem with low risk of morbidity for which treatment is considered. There is little to no risk of mortality with treatment, and full recovery without functional impairment is expected. A problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. And examples of this may include cystitis, allergic rhinitis, or a simple sprain. Next, we move on to the amount and/or complexity of data to be reviewed or analyzed. And in order to meet that limited there, and terminology is important here. You don't want to say it's low because the terminology here is limited. So we can get either category 1 or category 2 here. Category 1 is tests and documents. So review of a prior external note from each unique source, review of the results of each unique test, and then ordering of each unique test. Now you can't double dip here. You can't do 1 test, order it, and review it and count 2 points there. You either get one or the other, review or order. And then category 2 is assessment requiring an independent historian. The independent historian is an individual. It can be a parent, guardian, surrogate, spouse, witness who provides history in addition to the history provided by the patient who is unable to provide a complete or reliable history. So maybe that patient has dementia. Maybe they are, a child. Maybe they are in a state of psychosis or delirium. They're heavily intoxicated and they can't really have a reliable history for what's needed for healthcare purposes. So they are getting a confirmatory history from someone else, that another individual, that independent historian. It says, in the case where there may be conflict or poor communication between multiple historians and more than 1 historian is needed, the independent historian's requirement is met. And now this is where it gets really subjective, is if we look here at the risk. The only definition we have here for risk is low risk of morbidity from an additional diagnostic testing or treatment. So really what CPT tells us is that the level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may be low risk. The definitions of risk are based upon the usual behavior and thought process of a physician or other qualified healthcare professional in the same specialty. Trained clinicians apply common language usage, meaning such as high, medium, low, minimal risk, and do not require quantification for these definitions, although that's helpful, right? So the provider can just state it is low risk. There should also be supporting clinical decisions that support that low risk as well. They can't just say that something is high risk but not have the documentation that would support that decision of it being a high risk. So in order to hit that level 3, we could have a patient that just has one stable chronic illness and is low risk, or we could review and order a test in their low risk, or they could just have one acute uncomplicated illness or injury, maybe a urinary tract infection, and we ran some different testing on them, 2 different types of tests, or reviewed one test and ordered another test, and that would count for a level 3 service. Now, when we start getting into some situations where we have that acute injury, but it's like complicated and we're doing prescription drug management, that's when we might start thinking more it's a level 4 level of service. And you know what, since it's just so little, I'm going to actually cover the level 2 as well. So a level 2 is deemed a straightforward, which means we just need a minimal, so one self-limited or minor problem, minimal decision making, minimal risk of morbidity. So that one is very subjective. A level 2 really does get driven just by almost a lack of documentation, more so than a lot of supporting documentation. Now, in my next video, I want to cover the 99211. And the reason I think this deserves a full video for itself is because I also want to cover the confusion between when we can bill out a separate service with the 25 modifier, in most cases you can't. But I want to talk about that 99211 and then give some examples of some services where they may qualify for a 99211. And I'm curious to know, like, of all of the little definitions that we have in the AMA grid, which one do you still feel is just so incredibly subjective that you have trouble getting a clear answer on this fits in here and this does not fit in here? Let me know in the comments below because I really want to know. I will see you guys in the next video, and until then, just keep on coding on.